Okay, we are going to discuss a rather difficult topic, lung carcinoma. I've tried to make it very simple. I'll keep explaining the terminologies. In this PPT, the material is mostly theoretical. It is ratta. I've tried to make it as simplified as possible so that you'll absorb it easily. But there's one slide also here, which could come in your practical papers. 90% of 99% chance that it will be kept in your papers. So we'll see that also. Uh, Hopefully you'll understand this topic if I explain it well. Let's see. So lung cancer is the most common cancer in the world. So anytime somebody asks what's the most common cancer in the world, you know that most frequently diagnosed cancer in the world is lung cancer. It is also the number one cause for cancer related deaths, and it is a disease of older adults. So most commonly people from the ages of 55 to 80 years, and people who have history of tobacco smoking, and most common in males. So when you're taking history, you ask your patients what's their age, right? You obviously know their gender, you can tell. And then of course you see whether the person, you ask patient for their personal history. You're asking whether they're smoking, whether they're alcoholic. So when the patient presents to you, you can see, so this will be your presentation: an older male with the history of smoking, and how many years, and then you can calculate pack years from that, which increase the risk. There's a relationship it's out of the scope of pathology, but you'll discuss it in SPM. Now coming to etiology and pathogenesis, so there are three main risk factors. One, obviously you know, tobacco smoking, but there are other risk factors: industrial hazards for people who work in specific manual labor industries, and men are working more in those industries, so men are more at risk of those diseases. And although tobacco smoking is more common in men, so that's why men are more at the risk of these diseases, but women are more susceptible for unknown reasons. Women are more susceptible to the carcinogens, and of course pollution. So there are three main points: tobacco smoking, industrial hazards, and air pollution. Coming to tobacco smoking, so 80% of the lung cancers are occurring in people who are smoking at this moment, when they are having symptoms, or they're going for diagnosis, or people have stopped recently. So just because people have stopped, that doesn't mean that they are not at the risk of cancer, because the genetic changes that have occurred in their in the epithelium of the lung, they are going to persist. There is a linear correlation between the frequency of lung cancers and the pack years somebody has smoked. So for example, if somebody has smoked 2 packs a day, I don't know how many number of cigarettes there are in 1 pack, but if somebody has smoked 2 packs a day for 20 years, so there's a formula for this calculating pack year, and so these people will be 60 times more at risk for cancer than who do not smoke, and women have higher susceptibility for unknown reasons. Now, so this is what I was saying: genetic changes that predate lung cancer can persist for many years in the bronchial epithelium of former smokers. Now, it doesn't help that you chew tobacco. So smoking is causing lung cancer, but just because you are chewing tobacco, so many people in the central belt of India, UP, MP, and Bihar, so these people here are smoking, they are chewing a lot of masala and pan masala and gutka and all that, right? They're chewing tobacco also directly, so they are causing oral cancer. So we receive a lot of oral cancers in our histopathology lab, and these people and also have nicotine addiction. So they are physically dependent, they get constipated, they get symptoms if they don't. So you'll learn about physical and psychiatric dependence later, but in 4th year. But yeah, they develop constipation if they don't take nicotine. So smoking also, just smoking will cause lung cancer, chewing will cause oral cancer. And people who are sitting next to them, that is people, this is called passive smoking or second hand smoking. So people who are around habitual smokers, they will increase the risk for lung cancer, obviously. So it's called passive smoking. Now coming to industrial hazards, there's a lot of industrial hazards, but main you have to remember is asbestosis, and you have to remember that Hiroshima and Nagasaki survivors, they can develop lung cancer because the atomic bomb blast, obviously nuclear weapons, atomic bomb blast, they had or they have radioactive material in them, obviously. And then Chernobyl disaster, so the workers who were responsible for cleaning that up also at the risk. And then uranium, although uranium is not that radioactive, but it's still, people who work in uranium mines, they are more at risk. than people who won't. So asbestosis, arsenic, chromium, uranium, nickel, vinyl chloride and mustard gases, they are increasing the risk of developing lung cancer. High dose ionizing radiation as well, and obviously Hiroshima and Nagasaki atomic bomb blast survivors, Chernobyl disaster workers. Uranium, as I said, non-smoking uranium miners are 4 times higher than the the general population, and among the smoking, if you're smoking on the top of that, obviously the risk is 10 times higher. Now the relationship between asbestos and lung cancer. So whenever you're discussing a disease, so for communicable and non-communicable disease there is slight difference, but there's something called as natural history of a disease. So from exposure to for non-communicable disease I'm talking about, so like heart disease or lung cancer or diabetes, etc. So from exposure to the development of signs and symptoms, and then to treatment, and then after treatment also there is this sequelae of events that can happen that you learn. So this is called natural history of disease. So between exposure and signs of symptoms there is a time period. This time period is called latent period. So the patient is being exposed to this, the signs and symptoms have not yet developed. So this is called latent period, and for asbestos the latent period is 10 to 30 years. So people will keep working in asbestos factories, or sometimes people in their household develop asbestos in their roofs if they're not developed properly. So they'll keep living under those roofs and keep working in factories which have asbestos risk, and they'll not have any symptoms. Lung cancer is the most frequent malignancy in asbestos, and especially if smoking, because if there's no risk in people who are not smoking, they're not exposed to asbestos, there's no risk. They're exposed to asbestos, but they're not smoking 5-fold, but they're smoking as well, and they're working in asbestos factories, 55-fold risk. Now coming to air pollution, chronic exposure to air particulates and smog, lung irritation, inflammation and repair, and radon, radioactive gas, it also increases the lung cancer in uranium miners, particularly those who smoke. Now coming to mutations. So if you remember the chapter called neoplasia, there were 2 things that could cause neoplasia. Your cancer was caused by 2 things. Either by your proto-oncogenes, so proto means something inactive, right? So proto-oncogenes, which became, because of some event, they became oncogenic. Onco is cancer, genic is producing. So something which is producing cancer, proto-oncogenes became oncogenic. Or tumor suppressor genes, so something just that was suppressing the tumors, and because of some mutation, they have lost their function. So loss of function has happened, and they have also become oncogenic cancer causing, right? So chronic smoking causes this accumulation of oncogenic driver mutations. Either they can be, we'll discuss the mutation, they can be tumor suppressor genes have lost their function, or it is proto-oncogenes have become oncogenic, and that will transform the epithelial cells, will suddenly become neoplastic, and we know the malignant, the features that are seen in a neoplastic cell, a malignant cell. There is a term called field effect, which is used in relation to lung cancer. So this means that people who do not have lung cancer, just because smokers, we say that not every smoker can develop lung cancer. 80% of the lung cancers are occurring in smokers, but there are people who smoke but they don't get lung cancer. So just the benign bronchial epithelium in those people is still exposed to the mutations which are caused by carcinogens on the tobacco smoke. This is called as field effect. So the lung will still, so if this is a this is a lung which is exposed to smoking, and this is a person of somebody else who's not exposed to smoking, so if it doesn't develop cancer, but it will not still be completely normal. I hope you understand what field effect means. Just because it doesn't have cancer doesn't mean it is normal. It still has mutation. Now coming to the histologic type and their distinct molecular features, I have tried to minimize these things to make it a point just very specific, so that you remember it, like just remember the names, that's more important. So coming to adenocarcinoma, so we have 3 cancers when it comes to lung cancer. We have 3 types: adenocarcinoma, squamous cell carcinoma, the short term for that is SCC, and we have small cell carcinoma. When it comes to adenocarcinoma, it is also associated with tobacco smoking, but not as much as squamous cell carcinoma. But it is the most common subtype in never smokers. So it is the most common subtypes in females. It has gain of function mutation of growth factor receptor signature. Just remember, gain of function has happened. EGFR, ALK, ROS, MET and RET. And also BRAF and PI3K and KRAS gene mutations are also seen. Just remember the names. That in adenocarcinoma, this is the cancer which is associated with tobacco smoking, but not as much as SCC. It is the most common subtype in never smokers and women, and the mutations are EGFR, remember EGFR, KRAS and RET, and then you can remember ALK. Remember EGFR, RET and KRAS. Next we have squamous cell carcinoma. It is the one which is most strong, highly associated with it is the one that is highly associated with tobacco smoking. Just a second. So here the mutations that are happening is loss of 3p, 9p and 17p. Highest frequency of TP53 mutations of all the histological types, and TP53 mutations. So 10 to 50% of patients will have squamous dysplasia, and then 60 to 90% are developing SCC in situ, and eventually it will develop SCC, and then CDKN2A inactivation, and its protein product is lost in 65% of the tumors. So if you were to summarize, so there is loss of CDNK2 because of which its protein product is lost, and then we have 17p, which is the site of p53 gene, and it is the out of all the cancers of lung, the three cancer, adenocarcinoma, squamous cell carcinoma and small cell carcinoma, TP53 is in highest frequency in SCC. And if you remember the function of TP53, it's the guardian of the genome, and FGFR amplification. So obviously if it has lost its function. Now coming to small cell carcinoma, strongest association with smoking. It shares many strongest association, but highest is in squamous cell carcinoma only. And it also has TP53, but not as it has TP53, but not as much as in squamous cell carcinoma. RB close to 100% of the tumors, and then chromosome 3p deletions and MYC family. Just remember TP53 and RB and MYC. Just remember these. Now lung cancers in never smoker. So as per WHO, 25% of the lung cancers worldwide occur in never smokers. This percentage is probably close to 10 to 50% because now the screening has increased. This is more common in women and mostly are adenocarcinomas, like we already discussed, and this is mostly. So you have to remember, if somebody says what are the points, if you have to write it in points: lung cancers in never smoker, women, adenocarcinoma, EGFR, and these have never have KRAS mutations. KRAS mutations are directly related to smoking. We don't need to go that much in detail. Now coming to precursor or pre-invasive lesions. So they can be squamous dysplasia and so it's a sequence of events in a way. So first the dysplasia is happening, and then it become, or it could be just a hyperplasia, atypical adenomatous hyperplasia. So squamous dysplasia will become carcinoma in situ and squamous carcinoma in situ, and then SCC, full-fledged squamous cell carcinoma. Atypical adenomatous hyperplasia, then adenocarcinoma in situ, and then adenocarcinoma. Diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. These are difficult terms that you just have to rectify it. There's no other way around it. Now classification of lung cancer. So overall we know that three main cancers are important: adenocarcinoma, squamous cell carcinoma and small cell carcinoma. Now if we were to go in detail, all of this PPT I've directly copied from Robbins, your new Robbins. I've typed it all and edited it all from the older one. Okay, so this is from that only. So adenocarcinoma, so it can have lipidic type, acinar type, papillary type, solid type. So in adenocarcinoma of lung can have all these patterns, right? But so whenever there is a tumor, there is normal mucosa, there is normal epithelium, normal histology, and there's a tumor occurring. So you have to describe what does it look like. So that's called a pattern. What does it look like? In lung cancers, when we say about the pattern, there can be many patterns, but the predominant ones can be lipidic, cynar, papillary, and solid. These can be all admixed. Then invasive mucinous adenocarcinoma, and then minimally MIA, minimally invasive adenocarcinoma, can be non-mucinous or mucinous. Squamous cell carcinoma, keratinizing, non-keratinizing, and baseloid. We'll see a slide of squamous cell carcinoma which you can get in paper. Neuroendocrine tumors, small cell carcinomas, combined small cell carcinomas, large cell neuroendocrine, carcinoid tumors, and others. Now coming to clinical features. This is one of the most insidious and aggressive neoplasms. These are older males which have several months of duration of the symptoms. It's not कि 2 हफ्ते की खांसी नहीं है उसकी, ठीक है? It's been several months that he's having cough, he's having weight loss, he's having chest pain, he's having dyspnea. These symptoms together, all these symptoms together along with an older male, you have to think. This will be your DD that you'll keep in mind. So this again I've copied from your book only. So local effects of lung tumor spread. If the central airways are affected, you will have cough. Hemopsis, if the hemorrhage is occurring in the tumor, you will have the blood in your cough. Hemopsis, you know, na? Blood in your cough. Extension of tumor into the mediastinum or pleura or chest wall. We know that one of the parietal pleura is not painful, visceral pleura is more painful. So whenever the tumor has gone in that pathway, chest pain will occur. If the airway has been obstructed, then pneumonia, abscesses, collapse, tumor obstruction and accumulation of cellular lipid and foamy macrophages, lipoid pneumonia. So these SVC syndrome and Horner syndromes are important. That remember SVC syndrome, Horner syndrome, cough, hemopsis, chest pain, and pneumonia and effusion. Just remember these. That doesn't mean that you don't read the others, because diaphragm paralysis can occur if phrenic nerve has been invaded, rib destruction, dysphagia if esophagus is involved. So depending, and hoarseness can occur if recurrent laryngeal nerve has been involved. So whatever is the site of involvement, that will be the cause of clinical features. So anytime you have a symptom, there is a reason for that symptom. Some organ, some site is being affected. Now coming to the morphology. So atypical adenomator hyperplasia. So basically what is happening is, we know what is the epithelium, right, of lung. We know pseudostratified columnar epithelium. But in atypical adenomatous hyperplasia, the epithelium has become cuboidal. It's a small lesion. It's a small lesion. Remember that you have to try to remember everything in points so that you don't forget it. Less than equal to 5 mm, small, dysplastic pneumocytes, and they line the alveolar walls, and the walls have become fibrotic. So this is normal looking. This is the pattern of this tissue is normal only. This is how normal lung is. But these cells have become dysplastic. They can be single or multiple such foci in the lung adjacent to or invasive tumor away from it. So it's not something you'll see macroscopically, okay? It's a microscopic finding. Now coming to adenocarcinoma in situ. So it can be mucinous or non-mucinous, correct, depends. So the pre-existing septa that you have, so former name, it was called bronchoalveolar carcinoma. Again, it is less than 3 centimeter. It is less than 3, composed of dysplastic cells which are growing on the septae. Though the hyperplasia was also dysplastic cells growing along the septae only, the wall only. But the problem here, the dysplasia is more. So the difference from that one is here the dysplasia is more than the atypical, and mucin can be present. If the mucin is present, it's mucinous subtype. If it is not present, it is non-mucinous subtype. Now coming to the morphology of adenocarcinoma. So here you see a lung. This is a lung cut in half, and these are not 2 lungs. This is 1 lung cut in half. So this is a tumor that you see in the periphery, right? So adenocarcinoma tend to be peripheral and smaller than squamous cell carcinoma. Squamous cell carcinomas tend to be central or hilar in location. Coming to adenocarcinoma, it's an invasive malignant epithelial tumor with glandular differentiation. So we remember, right? Every in last topic also we were discussing adenocarcinoma of stomach. So when there is adeno, there will be glandular, right? So always remember that. So invasive because it is a carcinoma. So when you say in situ, like the last to last slide, in situ, it means that it's not invasive. It's non-invasive. In situ means it's non-invasive. That is the basement membrane of your tissue. The cancer cells are seen below it. So if this is your tissue and this is your basement membrane, the cancer cells are below it. They are not going outside the basement membrane. That is intact. So it's called non-invasive. So it's an invasive carcinoma with glandular differentiation or mucin production. It can have several patterns: acinar, lipidic, papillary, micropapillary, and solid. Now this is a acinar pattern. If you remember gastric adenocarcinoma, I told you how does a gland look on histology. So this is a central lumen. Glands are empty spaces. They are walls surrounding the empty spaces. It's a like a pouch. A gland is like a pouch, okay, because secretions are in उसमें. So center में lumen में you might this little what you see is secretions, and these are well differentiated tumors. So proper you can see glands have formed. This is not normal lung histology. And these are glandular elements, and they have stained the cells. This is IHC with TTF1. So thyroid transcription factor TTF1, usually it is identified in thyroid, but it is also responsible for normal lung development, and hence it will also be expressed in whenever you have lung cells, your cancer cells in lung are proliferating. Now I'm just describing these terms so that you remember what you don't have to remember this in detail, that adenocarcinoma has this pattern. I'm just describing it and putting it in separate pictures so that you remember the names, that adenocarcinoma can have this pattern, this pattern, this pattern. There's something called a lipidic pattern. So here the tumor cells will crawl along the normal appearing alveolar septae. So here you remember, right, that this was the glandular. This is not normal. But in lipidic one, these are normal looking alveolar spaces, and the tumor cells are crawling. So it looks like a butterfly crawling over wood. It's called lipidic pattern. Now coming to the acinar adenocarcinoma, so it can have mucinous cells. These are mucinous cells that you see. Again, I don't want you to go into detail, just remember the names. That's why I'm putting in pictures. Anytime there is a word papilla means thumb like projection. So you see, this is the tumor cells in papillae. This is the center mein, if you can see RBC's fibrovascular core is seen. That's why it's a true papilla. Micropapillary, small papillae, small thumb-like projections. Now invasive. Now the tumor cells having goblet or columnar cell morphology with abundant mucin and small basally oriented bland nuclei. Anytime the word bland comes, that means it looks benign. But these mucinous cells are not normal. Normal lung does not have mucinous cells. These mucin filled empty spaces. These goblet like cells, like as if they were in your intestine. If you see the normal intestine morphology, it has goblet cells. So it looks like them. These empty looking cells, they look like goblet cells. Microinvasive. So these are tumors less than equal to 3 centimeter with a small invasive component less than equal to 5. There is associated scarring, and there is a peripheral lipidic growth pattern, and they are far better outcomes obviously than the invasive ones. Mucinous adenocarcinomas tend to spread erogenously, forming satellite tumors. So they spread through airways. Erogenously means through airways. So they have satellite nodules like this. They may present as solitary, that is one nodule, or multiple, or an entire lobe may be consolidated by tumor, which will resemble lobar pneumonia. That's why it's less likely to be cured by surgery, because the entire lobe, if it's gone. Now coming to the most aggressive of types, which is the squamous cell carcinoma. If you've discussed the adenocarcinoma and the patterns seen in it, now we're coming to the squamous cell carcinoma, and then we'll discuss the small cell carcinoma. And after that, I've tried to keep it very, very brief. It's an aggressive tumor. Distant mets usually occurs in main or lobar bronchi, that is centrally located. So this was an older vision, that it is only seen in the central location or lobar bronchi, because these days squamous cell carcinomas have started to occur in the periphery, just like the adenocarcinoma. Strong association with smoking, more common in men, and it can have infections. Pneumonia also can occur, and atelectasis, which is complete collapse of the lung, that can also happen. Now on gross, it's a cauliflower-like growth. If you see, it's a cauliflower-like growth. Gray-white, it's when you touch it, the consistency is firm to hard. If it is large, there will be hemorrhage and necrosis also. And sometimes these can cavitate. That means these wherever you see these black, this is necrosis. So they can form cavities, empty spaces. Microscopically, the presence of keratinization and / or intercellular bridges. Just remember these two words. Keratinization and intercellular bridges and squamous pearls. Just remember, if you remember these three words in SCC, which is keratinization, intercellular bridges and squamous pearls, you are sufficient. Just in the morphology of SCC, just remember three words: keratinization, intercellular bridges, squamous pearls. You don't have to describe anything else. So now this squamous cell carcinoma can be very well differentiated or poorly differentiated. So very well differentiated have good prognosis, poorly differentiated, poor prognosis. And curtain pearls are more common in, this keratinization is more common in well differentiated. Now this is something that you can see in practicals. So this is a keratin pearl. This thing, the central pink thing is a keratin pearl. In a poorly differentiated carcinoma, you will not see. So I've put in the next slide, I've put various types of various pictures of keratin pearls so that you'll remember it. Take a screenshot of it, or Google keratin pearls. You will definitely get this in paper. In your spotting, this picture will be put. You have to write, you see keratin pearls in squamous cell carcinoma. You have to write just that. So these are keratin pearls. So basically keratinization is happening in the tumor. So because of which round concentric circles are formed. All of these are keratin pearls. Just remember keratin pearls. You can get this in exam in practicals, okay? Squamous, now last entity, small cell carcinoma. Highly malignant tumor, strong relationship to smoking, but can occur in non-smoker. Risk factors are your aromatic amines. It has no known pre-invasive phase. So both when it comes to pre-invasive phase, both of them adenocarcinoma and squamous cell carcinoma had a pre-invasive phase. This one does not have any pre-invasive phase. It's the most aggressive of lung tumors. It can cause SVC syndrome and effusions and hilar vessels invasion into the vessel is common with it. Now microscopically it is composed of small cells. So it's called small cell carcinoma. So what do you mean? Any time you use any criteria, especially in pathology, in general, in medicine, you can't. Any time you're using a word, there is some comparison with it. So where does this? When you're saying small, you must mean something, na? How small? So they're smaller than 3 times the diameter of a small resting lymphocyte. So if it's a lymphocyte, in the nucleus. The lymphocyte 3 times the small, it's not exactly 3 times, but I'm just trying to make you remember that 3 times the size, smaller than 3 times the diameter of a small lymphocyte. So these are small cells. These are small cells with scant cytoplasm. So basically only nuclei is seen, and this nuclei has salt and pepper chromatin. Just remember, small cells smaller than 3 times the diameter of a resting lymphocyte, number 1. Number 2, salt and pepper chromatin, and also scant cytoplasm, third point. Only nucleus is seen. And what do you see in the nucleus? Salt and pepper chromatin. Remember this term, okay? So salt and pepper chromatin, this is a pattern of chromatin which is seen in neuroendocrine tumors. And small cell carcinoma happens to be a neuroendocrine tumors. Now, when we say neuroendocrine, is because everywhere in body, wherever neuroendocrine tumors happen, there is a component which is neural and endocrinal. That is, it is secreting hormones and it has a neural function. That it is involved in sensitivity. There is nerves in every organ, right? So it is involved in some neuroendocrinal function as well. So small cell carcinoma is your neuroendocrinal tumor, and because your lung has normal lung epithelium has limiting basement membrane which has neuroendocrinal component which can have tumors. So the mitotic count is high, the cells grow in clusters, and they are neither glandular, that is they are not adenocarcinomas, they are not squamous, so they are not SCCs, but necrosis is common and extensive. Now this is another thing you have to remember. So you remember that Azopardi effect. Azopardi effect is something basophilic staining of the vascular walls due to incrustation by DNA from necrotic tumor cells, because like we said na, the necrosis is common. So these necrotic cells, the DNA which is released from the necrotic cells, it gets attached to the vessel walls, and they get and there is a basophilic staining of those cells. So necrotic cells release the DNA which gets attached to the vessel walls because of, and which get basophilic staining, and it's called Azopardi effect, which is only seen in small cell carcinomas of lung. You will not hear this term anywhere, Azopardi effect. You will hear only here only, and these are all high grade. Whenever there is high grade, there will be necrosis, there will be hemorrhage. On electron microscopy, you can see neurosecretory granules, and again this neurosecretory granules is a feature of neuroendocrinal tumors. How do you know that it is a neuroendocrine origin? So it has neurosecretory granules, it has chromogranin and synaptophycine. So whenever you say a tumor, the origin of a tumor is neuroendocrine, you mean three things. Many things, but these five things. Neurosecretory granules, chromogranin synaptophycine, CD56, and they secrete hormones, PTHRP, more common. I know this is a lot of rectifying things, but you'll keep repeating these through the 5 years of your MBBS, and then even in your NEET PG preparation, you'll keep repeating these things and they'll become a reflex. It will over time only, okay? So these are small, deeply basophilic cells, and these pink are these. This is the area of necrosis. These are do you see these dark purple things? These are all mitosis. Told you na, high mitotic count is seen. Whenever a tumor is dividing a lot, it means it's high grade. It's not well differentiated. It is poorly differentiated, and it has a lot of mitosis and a lot of necrosis. Again, these are islands of cells. Now I have only described it a little bit. I told only 3 entities are described, but just a little bit of the large cell carcinoma. It's an undifferentiated tumor. It's a diagnosis of exclusion when you've said there's a tumor in lung, but you are saying it's not adenocarcinoma, clearly it is not squamous cell carcinoma, it's not small cell carcinoma, then you go to this diagnosis. It has morphological features similar to that of a characteristic small cell carcinoma, but only it has not small cells, it has large cells. So it's also neuroendocrine, just like the small cell one. It has large nuclei, prominent nuclei, and moderate amount of cytoplasm. So you see these dot are nuclei and moderate amount of pinkish cytoplasm, and this is your large cell carcinoma. Now coming to the secondary pathology which can happen in lung carcinomas. They can be emphysema, atelectasis, bronchitis or bronchiectasis. Abscesses can happen, which can maybe call attention to an otherwise silent carcinoma. SVC syndrome, pericarditis or pleuritis with effusions, pericardial or pleural effusion. Horner syndrome or Pancoast tumors can occur. Now paraneoplastic syndrome can happen in lung carcinomas. For example, inappropriate secretion of antidiuretic hormone SIDH, adrenocorticotropic hormone secretion, which will produce Cushing syndrome, parathormone production, PTRH production, and all of these will lead to hypercalcemia. Calcitonin, which will cause hypocalcemia, gonadotropins, which will cause gynecomastia, serotonin and bradykinin, which are associated with causing carcinoid syndrome. So you will read paraneoplastic syndrome again throughout your life, and sometimes the patient does not present directly as a cancer, so sometimes they present as paraneoplastic syndromes. Lambert-Eaton myasthenic syndrome, peripheral neuropathy, acanthasis nigricans, hematological abnormalities like leukemia direction, Trossio syndrome, and hypertrophic pulmonary osteoarthropathy. So I know it's a difficult topic, but I've summarized it a little bit. There are three major histological subtypes: adenocarcinoma, which is the most common one, squamous cell carcinoma, large cell carcinoma. Sorry, I've just there are three types. Okay, I've copied it from the old one, so that's why there are four types. But there are three major types: adeno, squamous, and small. Smoking is the most important risk factor for lung carcinoma, but in women and non-smokers, adenocarcinomas are most common. Their precursor lesions like squamous dysplasia occur in squamous cancers, and atypical adenomatous hyperplasia and adenocarcinoma in situ for adenocarcinoma, but there is no precursor lesion for small cell carcinoma. Tumor 3 cm and less than 3 cm, they grow along the pre-existing structures of the alveolar septae. They are called as lapidic pattern, it's called, seen in adenocarcinoma in situ or adenocarcinoma in general. You can see this in lung cancers, particularly small cell lung carcinoma can cause paraneoplastic syndromes. Hopefully I've summarized this also simply. I know it's a difficult topic. All the best, and I will try to update you with the next topic that I'll be doing. Thank you.